BLS for adults, CPR. We also have CPR for babies, for neonates. When the baby comes out and is not feeling well, we can do CPR on it and get it breathing well and doing well. Okay, so that is what today's lecture is all about. And the CPR for the neonates is called ARP, Neonatal Resuscitation Program. So when you graduate, if you're going to work in the IC, in the NICU, okay, they will make you get at least that, okay, so that you know how to do CPR on the neonates, okay? Or maybe if you go to delivery, the rest of the therapy is called to attend the delivery of a newborn, okay? You would have that is required, okay? Any questions about that? I used to be an instructor for that, but when Polly took over teaching the babies class, I just kind of let my license expire. Because Polly's been teaching this for a while. I'm just teaching it for her this time around. All right. So introduction. A lot of newborns require assistance to begin spontaneous breathing at birth. Sometimes babies come out, they're not breathing well because they probably have a trachea that is plugged up with meconium and other issues, okay? So in those type of babies, we have to kind of do something to them, suction them out, maybe make sure that they're staying warm, stimulate them before they can start breathing, okay? Some newborns need extensive resuscitative effort to survive. Yeah, we may go all the way to giving them medication, doing positive pressure ventilation, bagging the baby, go all the way down, intubating them, giving them epinephrine, so that we can get them doing well and breathing well. The lives of 1 million babies worldwide could be saved by proper resuscitation, and that is true, okay? We're always ready, especially when you know the history of the pregnancy, okay, or how the pregnancy has progressed, okay? We'll be ready and be prepared for the baby to be born. Birth asphyxia accounts for a lot of neonatal deaths per year worldwide. That is true. Asphyxia is deprivation of oxygen to the baby. Okay. When a baby is born hypoxic, that is part of what starts their entire problem of not doing well. Okay. They cannot make normal transition to a standard life. Their pulmonary capillaries, pulmonary blood vessels, may remain constricted just like it did in Europe, okay? So that is called persistent pulmonary hypertension of the newborn, okay? The ductus may not close, okay? All of that is caused by asphyxia. So initial assessment immediately after birth. Once a baby is born, once they exit the birth canal, you're going to ask yourself 3 questions to determine whether the baby is going to do well or to go into the process of resuscitating the baby. The first question that you ask yourself once the baby is handed to you is, does the baby appear to be term? Okay. Now, term babies tolerate and respond to resuscitation well than babies who are not term, or babies who are preterm. Okay. Does the baby have good muscle tone? Okay, a baby that has good muscle tone will have their hands and their legs flexed. Okay, like that. That will be flexed. But a baby that does not have good muscle tone will have their extremities kind of like extended, okay, and not well flexed. So you look at the baby and determine that. Is the baby breathing or crying? Now, crying is a sign of the baby breathing, okay? If the baby is yelling out loud and fussing and doing all of that, that's good, you know. But if the baby is not crying, or maybe crying without vigor, okay, the baby's cry has to be vigorous. If it's crying without vigor, then you know that's a sign that the baby is not breathing well. Okay. So now down here it says that if the answer to the three questions is yes, these three questions here, the baby can stay with the mother. Okay. And then we just monitor the baby. Okay. While the baby is with the mother, make sure that the baby is warm. Frequently checking their heart rate, just monitoring the baby. But if the answer is no, then we know that the baby needs resuscitation, the baby needs some help to start breathing well. Okay? So that will put us to the initial steps of resuscitating the baby. So those initial steps are, the first thing there is to provide warmth. Make sure that the baby is warm enough. We're going to immediately transfer the baby to a radiant warmer, okay, or radiant heater. You know what I'm talking about, you know. And that's one of the ways that we can keep the babies warm, okay. Because you know, if you keep them very warm, they are going to tolerate resuscitation well. If they are very cold, actually they may go into what we call cold stress. Now, anytime somebody gets cold, okay, anytime somebody gets cold, they will undergo metabolism. If you remember, metabolism is what generates body heat. So the same thing with babies, but the difference is that babies make a brown fat. Brown fat. In the womb, they make a brown fat, and once they are born, in like the first month or two or so, when they undergo metabolism, they use the brown fat. But in us, we use glucose, right? We use glucose, but babies use brown fat. So that's the way they generate body heat. So we don't want them to be cold because we want them to try to preserve the brown fat so that they don't deplete the brown fat that they have until they start undergoing metabolism the way we do. Okay, so that's why, that's called cold stress. We want to keep them warm so that they don't continue to use their brown fat to undergo metabolism. Okay? Now, the second thing is that we're going to position the baby's head and the neck to open up the airway. Okay? Kind of like extend your neck a little bit. Like that. Okay, not hyperextend. Okay. When you do that, you align the lower airway with the upper airway. Okay, so that they can breathe very easily. We can clear the airways of secretions. We can use a bulb syringe. Syringe. suction their mouth and their nose out. Make sure that there are no secretions in the way of them trying to breathe in. And then we dry and stimulate the baby. By the time they are doing these other three things anyway, the baby should have felt you, because usually when you begin to touch them, okay, you're already stimulating them, But now, after the first three, if the baby is still not breathing well, you can stimulate them to breathe. So basically what you do is you rub the, gently rub their back, okay, like that. Or maybe you can rub anywhere down in their extremities. Just kind of rub it. And then that will start them going. Okay? So these are the four initial steps of resuscitation. So now, babies conserving body heat is very important. These are the four ways that a baby can lose body heat. Okay? The first one is what we call radiation. Radiation. And radiation is a transfer of heat, the transfer of body heat from the baby, okay, to objects that are not in touch with the baby, that are around the baby but not in touch with the baby. Okay, cooler objects, let me refine that. Transfer of heat from the baby to cooler objects that are around the baby but not in touch with them. Okay, have something cold around them but it's not actually touching them. Heat can go from their body to that cooler object. And the way we prevent that from happening is putting the baby under that radiant warmer. Okay? That will prevent them from losing body heat to cooler objects around them. Any questions about that? And then they can also lose body heat through conduction. And this is the transfer of heat from the baby to cooler objects that are in contact with the baby's skin. Okay? Like you have a cold blanket or a cold towel, where the baby is lying down. So they lose body heat that way. So what we have to do is to make sure that the blanket that the baby is going to lie down on will be warm, pre-heated or pre-warmed blankets. If you're going to dry them up, you're going to use a warm towel, and not something that is cold to do that. And then you can also lose body heat through convection, which is the transfer of heat from the baby to cold air around the baby, any cold air around the baby. There's something called the cold draft. You have to minimize like movement across the baby, because anytime you move past the baby, cold air goes to it, So you minimize movement around the baby so that they're not losing that body heat to cooler air. They can also lose body heat through evaporation. If they're cold or wet, okay, they try to generate their body heat because they're cold. And then they are losing their heat to the surrounding atmosphere. So to prevent that, we have to make sure we're drying them up. Use one towel, you dry the baby up, so they don't try to generate body heat that they're going to lose through their skin. Any questions? Measuring newborns' response to initial steps. Those 4 initial steps that we talked about. How are you going to measure that after you've checked on those? What we're going to do, the first thing we're going to do is to check respirations. If the baby is not breathing or has gasping respirations, we're going to start PPV, which is positive pressure ventilation. If they are apneic or gasping for breath, Now, gasping for breath, they treat it like apnea because when you're gasping for breath, your ventilation is not very, very effective, neither is it adequate. So they pretty much treat it like apnea. Okay? The baby's heart rate should be assessed while PPV begins. Now, PPV should improve heart rate. Okay? Positive pressure ventilation is number 1 thing that increases the baby's heart rate if it's less than 100 beats per minute. So during resuscitation, if the baby's heart rate is not increasing, then you got to check and make sure that you're ventilating the baby well. Okay? Not necessarily the amount of oxygen, but ventilation. So the next thing that we can do to check on the response for the initial step is the heart rate then. If the baby's heart rate is, if the baby is breathing fine, the heart rate should be at least 100 beats per minute. It is best to use a stethoscope to determine the heart rate. Okay? Long time ago, we used to grab the umbilical stump where you cut the umbilical cord. If you grab it, you can feel it pulsating. You can use it and count the heart rate, but I'm not doing that anymore. Okay? Because sometimes you may not count well, you may be distracted, that kind of stuff, and then it doesn't come out well enough. So now the modern or the most current NRP guideline says that you should use a stethoscope, okay, to assess their heart rate. So now, you're going to count 6 seconds, okay? How many heart rate did you hear in 6 seconds? And then you're going to multiply that by 10. Okay? Like if I heard 12 heartbeats in 6 seconds, I multiply it by 10, the baby's heart rate will be 120. If the baby's heart rate is less than 100, then you begin PPV. Okay? If the baby has a heart rate greater than 100, it is not apneic or gasping, but has labored breathing or cyanosis. We can consider using CPAP. Okay? Because if before somebody can be on CPAP, they have to be breathing. CPAP is spontaneous breathing. At a positive baseline. Oh, that reminds me, let me give you this algorithm. That's basically what we're looking at here.
Okay.
Okay, so again, indications for PPV, positive pressure ventilation. The baby is apneic, okay? So we should start PPV. The baby is gasping for breaths. We should start PPV. The baby's spontaneous breathing does not result in the heart rate that is greater than 100. We need to start PPV, okay? During resuscitation, air failure to between 21 to 100% can be used. Now, studies have shown that there is not really any difference between between using room air for resuscitation and using oxygen up to 100%. Okay, either one of them will do. But the younger the baby is, the more tendency for you to use more oxygen. Okay? If the baby is dumb, you don't have to resuscitate anywhere, but if they need oxygen, they would need a whole lot. Okay, so you can technically use 21% to 100%, okay, for resuscitation. If the baby's oxygenation is not improving, if you're using room air, then that will be a reason to use some level of oxygen. Okay? Use SpO2 monitor, sub-monitor, and consider the use of EKG monitor during PPV. So you can monitor and see what the baby's oxygen saturation is to know whether you have to increase the oxygenation level. And of course, if the baby is getting adequate oxygen, then the heart rate should be normal, heart rate should be normal for PPV. So now, there are 3 ways that you can ventilate the baby. Let me see if I got there. I forgot to get that as well. You want to have a lab. We'll have one lab for this class. So you can use a flow inflating bag. I have a picture on the next slide. You can use a self-inflating bag or what they call the T-piece resuscitator to provide PPV to the baby. Okay? You want to make sure that the mask that you're going to use is properly sized. The mask should not cover the baby's nose or mouth and chin, but that's all. So that the mask used must cover the baby's nose, mouth, and chin, but not the eyes. Initially, you're going to be ventilating with a pressure of 20 to 45. But if you need to ventilate a thumb baby, you may use a pressure up to 40. 30 to 40. If needed, administration of PEEP can start at 5. You may use PEEP. The bags, there is a way to adjust the valve to create PEEP on the bags. You may use what they call an orogastric tube, which is like it's more like a feeding tube. Okay, now, because when you are bagging the baby, some air can go into their stomach, okay, and then result in gastric distension. Okay, they become bloated. Okay, so to prevent that, if you know that you're going to be providing PPV for several minutes, then you have to put down like an orogastric tube, which is a feeding tube, to expel any air that may be going into their stomach. Because now, if air goes into your stomach, it makes your ventilation even harder. Okay? It prevents the diaphragm from contracting effectively. Okay, so that's why we want to make sure we're doing that. The baby is ventilated with a rate of 40 to 60 breaths per minute. Okay, so here are the devices that we can use to provide PPV. So this one here is a flow inflating bag. The reason for that is that the bag attached to it will only inflate when you hook it up to a gas source. Like you hook it up to oxygen, turn up your flow, or air. Okay, that's the only time it will inflate. Otherwise, it will remain deflated. Okay? It has the capability of delivering 100% oxygen. Okay? There's a little thing here. This is pressure manometer. Like when you squeeze, okay, the needle goes up. It tells you about how much pressure that they're using to ventilate the baby. Now, if you're in the red area there, okay, that means that the pressure will be very, very high. Okay, so you want your pressure in the green area. Okay, so that's what that is. There is a flow control valve here, okay, that you can close or open. If you want to create more PEEP, you kind of close it up a little bit. If you want to reduce PEEP, you open it up. Okay, that's what that does. Okay? And now, this one here is called a self-inflating bag. A self-inflating bag, because you don't have to hook it up to a gas source before it can inflate. Just like the bags that we use for adults. If you squeeze on it, whether you have it hooked up to oxygen or not, it's going to re-inflate by itself. Okay? So you have a choice of using that one, but this one here, okay, cannot quite provide 100% oxygen. But if you have a reservoir, there's a little bag that we put back here, or maybe a long tubing. If you remember that, we'll put in the tail of this here. So that's called a reservoir. Okay? So what the reservoir does is to prevent rumor from coming into the bag as much. So if you're using a reservoir with self-inflating bag, you can achieve anywhere between 90 to 100% oxygen. Okay, you'll be lucky if you get 100%, but it will be over 90%. Okay, with that. And like the flow inflating bag, you can have pressure manometer on it. You know, you have a place there to adjust your PEEP if you're going to use PEEP. Okay, and then this one down here is called a T-piece resuscitator. C-piece resuscitator. Okay, this one here can provide CPAP. Okay, it provides CPAP. You set your PEEP. Okay, and then you set your PIP, respiratory pressure, on this one here. And then you can see here where it is being used on the baby. There's a little thing here at the end of that tubing. Okay, once you hook it up to the airway or to the mask, if you occlude it, the pressure, the breath goes to the baby. You open it up, baby exhales. You occlude it, breath goes to the baby, and then you open it up. That's what that guy is doing there. So 3 ways that we can ventilate the baby. Okay, so now, like I said before, PPV should improve the baby's heart rate. Okay, PPV should improve the baby's heart rate. So if you're ventilating the baby and the heart rate is not going up, somehow you're not bagging them very well. Okay? You have to reassess what you're doing wrong. So the corrective action when the heart rate is not going up upon providing PPV to the baby is what they call Mr. SOCA. Now Mr. SOCA is like an acronym that they use to remember everything that you have to troubleshoot to see why the baby's heart rate is not going up with ventilation. So in that acronym, the M stands for mask adjustment. Maybe you don't have the mask applied well on the baby's face. You have to look at that and make sure that you reapply the mask and see that's where the problem is. The R means reposition the airway. You're going to make sure that the baby's head is a little extended, not half extended, so that the upper airway will line up with the lower airway. So when you're bagging, the air will be going into their lungs. The S in the Mr. SOPA stands for suction mouth and nose. They use a ball syringe, suction their mouth. Maybe they have secretions in their nose or in their mouth that is obstructing ventilation. The O stands for open mouth, okay? Which is kind of like, lift the jaw out a little bit. Okay, jaw thrust a little bit. That's another way to make sure that the airway is open, so that when you're backing, the air is going in. And then the P stands for pressure. Increase the pressure. Make sure you have the right amount of pressure. Like we said, you start with, what did I say, 20 to 25 or 25 probably? Okay. So make sure you have the right amount of pressure. If you're bagging with 25 and you think it's not enough, you're not having adequate chest rise and fall, well, you can increase your pressure to 30. So increase your pressure in increments of 5 to 10. And then the air in Mr. SOPA is alternative airway. So if we're bagging them with a mask and that is not working, then we need to consider intubating the baby, okay? So we can have a better airway, or maybe using a laryngeal mask airway to provide ventilation. Okay, so now you're providing PPV to the baby. After 30 seconds, you have to assess the baby's heart rate. Assessment of the heart rate is what tells you whether you are providing adequate ventilation to the baby. Okay, so if the baby's heart rate continues to be less than 60 seconds, or is less than 60 seconds, after you have provided a PPV for 30 seconds, you need to start chest compressions. Start chest compressions. Intubate the baby if you haven't already done that at this point. Okay, because eventually you're going to have to coordinate chest compressions with ventilation. Okay, how many compressions will you do for one ventilation? You're going to have to coordinate that. Chest compression increases intrathoracic pressure. Okay. The heart is compressed against the spine. Okay. And when you're doing chest compressions, what we really do is to squeeze out some blood, from the heart, so that we can increase cardiac output. Okay, that's why we do chest compressions. Okay. So when you compress, you're going to compress at the rate of 90 per minute. 90 compressions per minute is what you need to do. And what is the depth of compression? We don't want you to break the baby's ribs, but so you have to be very gentle. Make sure you're not compressing very deeply. Okay, we need to compress to a depth of 1/3 anterior posterior diameter of the chest. Okay, that's the guideline. 1/3 of the anterior posterior diameter of the chest is the depth of compression. Okay, and how do you provide compression? You're going to use what they call the thumb technique. let's say that, I don't have that baby to demonstrate that. So let's say that this is my baby. Your hands should encircle their thorax, like that, okay? And you use your two thumbs and place it like that, lower third of the sternum, like that. And then 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. And 1 and 2 and 3, just like that. Okay? You're gonna compress them. So, at this point we're doing coordinated compression with ventilation. So you're going to be compressing, doing 3 compressions for any one breath. So you do 1 and 2 and 3, and then the other person assisting you will breathe the baby. Okay, will back 1 and 2 and 3. The other person will back. Okay. You do that for 2 seconds. Okay, you always kind of like reassess every 2 seconds. Okay? Any questions about this? Now here's intubation. Indications for intubation. Intubations. No, that's right, indications. Okay, PPV is lasting more than several minutes. You've been doing mask ventilation for several minutes, but the baby is not improving, especially with your heart rate. It's not picking up either. Okay? And then we're going to go ahead and intubate the baby. Just for your information, the baby's ET tube is coughless. It doesn't have any cough. Okay? Bag and mask ventilation does not result in clinical improvement. That clinical improvement is increasing heart rate. We want your heart rate to go above 100. Okay, so if that's not happening, that will be a reason to intubate the baby as well. These are the equipment that we need to make sure we have them during delivery. You're going to have your laryngoscope. You're going to have your laryngoscope blade. Now, the Miller blade is preferred. The Miller blade. You remember the Miller blade and the Macintosh? The Macintosh is a carved blade. The Miller blade is one that is not carved at the end. They prefer using the Miller blade because with the Miller blade, you don't have to actually lift, place the end of it inside the vallecula to lift, okay? With the Miller blade, what you do is you find the epiglottis, and then you use the tip of the Miller blade to pick up the tip of the epiglottis. So you are actually picking up on the epiglottis. Now, with the curved blade, when you are intubating with the curved blade, you place the tip of the curved blade in the vallecula. Like that. Vallecula is like the base of the tongue and the epiglottis. That's where you put the curved blade and then you lift, and the whole thing goes up, including the epiglottis. Okay, but with the Miller blade, you find the epiglottis, and then you're just lifting up the tip of the epiglottis. So there's always less damage done to the baby when you use the Miller blade, as opposed to using the curved blade. Okay? And then size of ET tube. Now, the ET tube is cuffless. Remember, when you have a cuff, you have to put some air in it to create pressure. We don't want the pressure, okay? And the baby's tissues, okay? because that can cause some problems. It can cause fistula to develop in the baby. It can cause what they call tracheal malacia. That is softening of the tissue where the cough is pressing. Okay, tracheal malacia. And then we also have tracheal stenosis. That can cause hardening of the tissues where the cough is pressing. So because of all of that, it's better off we're better off not using a cuffed ET tube for the baby. So if you're going to intubate a baby that is less than 28 weeks, you're going to use 2.5. If you haven't seen the ET tube, I'll show them to you where we have a lab. It's like a straw, okay, very tiny ET tube, okay? And then if baby is 28 to 34 weeks, you use number 3. Number 3 is a little bigger in terms of diameter compared to 2.5. And then if the baby is greater than 34 weeks, you use 3.5. You're going to use suction catheter. Now, if you have ever intubated an adult, before we intubate an adult, we use the Yonker, right? We use the Yonker and clear the secretions from the upper airway so that we can visualize, the lower airway very well. For babies, we use suction catheter. We then use the Yonker. We use a suction catheter to do that. You need manual ventilation bag. You need a colorimetric device. Now, colorimetric device is that CO2 detector, okay? They call it the Easy Cap. You know what I'm talking about? The Easy Cap is pink, purple in color, okay? In the presence of CO2, it will turn yellow, okay? It will turn yellow. So that after you finish intubating the baby, you put it there on top of the ET tube, and then if you're inside the lungs, the baby is exhaling CO2, that causes the easy cap to turn yellow. Okay? Colorimetric device. And I must warn you about that easy cap. Okay? Sometimes if there is not enough perfusion, okay? Perfusion is measured by the amount of CO2 that comes around to the lungs, okay? If there's not adequate perfusion, meaning that the baby is not being adequately ventilated for some reason, when you put it there, it may not turn yellow right away, okay? The same thing with adult patients, like if you have somebody who's had cardiac arrest for few minutes and nobody found them. They were found like 10 minutes after they had cardiac arrest. They are very cold, okay? Once you intubate that patient and place that easy cap on top of the ET tube, you still remain purple. But as you begin to do CPR, okay, and increase perfusion, CO2 begin to come around to the lungs, and then it turns yellow. Okay? So you have to be cognizant of that. Okay? It doesn't always work very well if there's not adequate ventilation being provided. Okay? You need your stethoscope. Okay? You're going to need tape to tape the ET tube. You need a stylet. A stylet is that little wire that we put inside the ET tube. What it does is the stylet provides rigidity to the ET tube. Okay? If you want to, you can bend the ET tube anyhow you want to bend it once you have the stylet in there. But if you're going to use the stylet, make sure that the stylet doesn't protrude, okay, from the end of the ET tube inside the airway, because that can traumatize the baby or even the adult. Okay, so you have to make sure it's hidden in there at the tip of it. And once you get your ET tube in, you remove your stylet first, even before you put pressure on the cuff. Here's our intubation technique. 3 minutes. Intubation techniques, you always look for the epiglottis. Okay? Epiglottis is a very good landmark to look for when you're intubating your patient. Once you see it, then if you're using the cuffed blade, you're going to go down right at the over to the base of the tongue and the epiglottis, which is the bellicola. Then you want to lift it up, and the whole tissue there goes up, and then you expose the airway. If you're using the Miller blade, then you're going to pick up the tip of the epiglottis. You don't have to put it in the bellicola. You lift up the tip of the epiglottis with the tip of the Miller blade. Okay? The laryngoscope is normally held, okay, in the left hand. That's where you hold your laryngoscope. Okay? And then you insert it in the left side of the patient's mouth. Okay? And then you sweep the tongue to the right. Okay, so just kind of do this. You sweep the tongue, you advance the plate a little bit, looking for the epiglottis. Once you see it, it's easy. Okay, once you see the epiglottis. Now, intubating a baby is easier, okay? Because, you know, in the adult, the epiglottis is kind of like pointed, you know, is elongated and pointed, you know? But in the baby, the epiglottis is still developing. It's kind of like this. They call it the omega shift. It's like intubating a cat. Okay? Intubating a cat. That's what it looks like. Yeah? So they're very easy, you know. I mean, it's kind of like that. So once you put it, the airway's right there. Okay? So now, these are the sizes that we can use. If it's a thumb baby, use number 1 blade, Miller blade. If it is a preterm baby, use 0 size blade. If they are preterm like 24, 28 weeks, you use 0, 0. Okay. The size of the blade is marked, okay, on the blade. Okay. And the lifting technique, we talked about, you should know that by now, that lifting technique is that you're going to lift up like that when you intubate. Okay, not like that. If you do this, you're rocking back. Okay, if you're doing an adult, you can break their teeth, lacerate their lips. You know, so you cannot do this motion there. You move forward and upwards, okay, when you lift. That should decrease the incidence of trauma. Let's take a break here now. What, 20 minutes maybe? Or 15? Why don't we take, let's take 20 minutes. We'll come back. As far as the NRP is concerned, the best way to confirm tube placement when you're doing that is the colorimetric device, that easy cap. Okay? Like I said now, it is purple in color. When it detects the presence of CO2, it will turn yellow. If it doesn't turn yellow, you probably need esophageal intubation. Also, the baby's heart rate should be rising. Once you intubate the baby and start bagging them, the heart rate should be going up. We can also use capnograph. The capnograph is also a device that detects the presence of CO2. But actually, with the capnograph, you have a readout of the amount of CO2 in the exhaled air. That's the difference between that and the easy cap. Okay, but both of them are what they will call litmus test. Okay, they take the presence of CO2. There are other means that we can use, though, to also confirm the placement of the ET tube. Audible and equal bilateral voice sounds. You can use that. Chest rise and fall. We can do that. And you shouldn't have any leak around the mouth during PPV. Okay? If you do, then it may not be inside the lungs. And I remember the ET tube does not have any cuff. Okay, but it's just big enough to seal their trachea. So it's like, in a way, it's like you got a cuff. You know? So you still should not have any air leaking out. Okay, what depth are you supposed to do? What depth are you supposed to insert the ET tube? Remember, for an adult, we use the carina as a landmark, 2 to 5 cm above the carina, but that's different for the neonates. Okay, it's based on gestational age. Okay, so if the baby is 23 to 24 weeks, very premature, you're going to do 5.5 cm. If they're 25 to 26, 6 cm. If they're 27 to 29, 6.5 cm. If they're 30 to 32, 7. If they're 33 to 34, 7.5. 35 to 37, 8 cm, and so on for 38 to 40, 8.5, and then 9 for 41 to 43. On the lips down. Now, another thing that we can use is laryngeal mask airway. Now, laryngeal mask airway does not go inside the trachea. Okay? What it does is to occlude the glottis right on the airway. Okay? It will occlude it, and then when you bag, the air just goes inside the trachea. Okay? You may have air escaping into the stomach too. But it's very rare as long as you inflate the mask very well. So this is what it looks like. You have a mask here, you have a tube, the back of it. Okay. You have a powered balloon that is used to inflate the mask. Okay. So basically what you do is you don't need any equipment to place this inside the airway. You use your hand. Because I've seen a question that said, you know, what tool do you need to insert a laryngeal mask airway? You just need your hand. You don't need a laryngoscope. So you flex the calf. Sometimes you may lubricate the back of it so that it can slide down very easily. And then you just shove it down. Okay? Until it cannot go anymore. It cannot advance it anymore. And you stop. Then it will occlude the glottis, okay? The opening of the airway. And then you inflate the calf, and then you start bagging, okay? So anytime that we cannot intubate, we can use laryngeal mask airway. Okay? So that's what it says. The laryngeal mask may be used if bag and mask ventilation is ineffective. Or intubation is impossible. Medication. Sometimes, usually, when you start bagging most of the babies, they should start doing well. Okay? Rarely would you have a baby that will need medication. Okay, but it's possible to have one. Okay? And then we have to start giving them epinephrine and stuff. Okay, so when do you give the baby epinephrine? Baby's heart rate remains below 60 per minute after at least 30 seconds of PPV that inflates the lungs. Okay? So you are bagging them very well, you know. You don't have any problem. Mr. Soka is okay. Okay? But still, the heart rate is below 60 after you've done it for 30 seconds. And another 60 seconds of chest compressions coordinated with positive pressure ventilation. So you are doing 3 to 1, 3 to 1, 3 to 1, 3 compressions to 1 for 60 seconds, and then the heart rate is still low. So we're going to give drugs now, and the first drug to give is epinephrine. Okay? What the epinephrine does is to increase the baby's cardiac output. The amount of dose given is 0.1 to 0.3 milliliter per kg of 1 to 10,000 solution. That's the percentage of the epinephrine is given. You may repeat that every 3 to 5 minutes, just like in the adult. Okay? You also may give the epinephrine through the ET tube if the IV site is unobtainable. If you can't obtain the IV site, you may put it through the ET tube. And then if you do that, there is a dose for it. It's more than if you're doing the IV. Okay? You may also give volume expanders. It's like giving them fluid. Okay, volume expander is fluid. Okay, especially if the baby has a history of blood loss. Okay, maybe they have what we call hypovolemia. Okay, low volume, low intravascular volume, or maybe the baby is going into shock because they don't have enough volume. Okay, and then we're going to give them volume. Okay, to increase their blood pressure. So one of the things that you can give them is normal saline. Selling, okay? That's usually what most people will get. And then we can also give O negative blood cross-matched with that of the mother if the baby has severe anemia. The only time you give somebody packed red blood cells is when their hemoglobin is low, okay? Otherwise, if it's just blood pressure problem, they have low blood pressure, but they have normal hemoglobin. You don't give packed red blood cells, you just give fluid. Okay? So, but in this case, baby had big time blood loss or whatever, we're going to give them packed red blood cells. But we have to make sure that it matches that of the mother. The volume may be given intravenously through the vein, or it can be given intraosseously through the bone, okay, through the bone marrow. Okay? And then, or maybe we can give it through the ET tube. So that brings us to after score. Now, after score is an objective way of assessing how the baby is progressing with resuscitation. It's an objective way of assessing how the baby is responding to resuscitation. It is usually done at 1 minute and then 5 minutes. The first 1 minute of birth you do after school, and then 5 minutes after that you do another one. If there's an improvement from the 1 minute to the 5 minute, then that means that the baby is doing okay. Okay? Now, the after score was, there's a lady called Patricia. Patricia Adler. That's the lady that came up with this way of assessing babies during resuscitation. So basically, what they do is they assess 5 different areas, okay? And then assign each of the areas from 0 to 2 points. So they're assessing the heart rate, they're assessing the respiratory rate of the baby, they're assessing the muscle tone, they're assessing the reflex irritability, and then they're assessing the color, okay? And then depending on what each area is, they assign assign number between 0 to 2. Okay, so we're going to go over that. I wish I had something better to write it. I didn't use it. Can you all see this very well?
Well enough.
Can you? I left it in my office. Okay, so you can actually use the word APGAR to remember the areas, the things that are assessed. That's pretty good. You can use the word APGAR. That's the way I remember them, APGAR, like that. Remember them, okay? So now, the first one is appearance, which is the same thing as color. You look at them, their appearance of their skin, okay? Now, so we'll go like 0, 1 point, 2 points. So, if we look at the baby, and the baby is blue all over, they have central cyanosis all over, they are very blue. That's ugly. We assign them a value of 0. Blue all over. Okay? If the baby's body is blue, but their extremities are blue, no, what did I say? If the baby's body is pink, but their extremities are blue, then that's peripheral cyanosis, or acrocyanosis, another name for it. We assign a value of 1 to it. View extremities. If the baby is pink all over, which is what we want, well, that's excellent, that's what we want, we're going to assign a value of 2 to it. That's appearance. And then P can stand for pulse, which is the heart rate. So, if the baby has no heart rate, that's ugly. We assign a value of 0 to it. If the baby has heart rate that is less than 100, we assign 1 to it. If the baby has heart rate that is greater than 100 beats per minute, that's awesome, that's what we want. Now, G stands for grimace. Grimace is like, we use it for reflex irritability. Now, grimace is like facial expression of disgust, okay? What you usually do is you poke the baby with a blunt object or kind of say something to scare them and see how they react to it, okay? If the baby doesn't do anything, they don't move, they don't start crying, okay? They're just there. I'm gonna call that no reaction. When you put them with a blank object on the wall, you say something scared them, you know. No reaction, that will be 0. That's not it. If the baby grimaces, makes face, that will be 1. Grimace, that'll be 1. If the baby has active withdrawal, like you put them and then they go like that, active withdrawal, flexed, that will be 2. That's what we want. And maybe the baby begins to cry, that will be 2. Okay. If you do something to scare them and they start crying, that will be 2. And then the other A can be activity, okay, which would be muscle tone. Activity, muscle tone. If the baby is limp, the muscle is flaccid, you know, they're limp. Okay, they look very tired and worn out. That will be 0. Maybe linked muscle flaccid. That will be 0. If the baby has some flexion, they're flexed, but they're not very flexed. Okay, because they're supposed to be like that. But if they're not very well flexed, it means that they don't have good muscle tone. So that would be 1. Somewhat flexed. Not very flexed. That would be 1. And then if the baby is very flexed with the leg and everything, that would be 2. And then the R stands for respiration, respiratory rate. If the baby is apneic, that would be 0. That's ugly. If the baby is crying, but it has cry without vigor, the cry is very weak cry, that would be 1. If the baby is crying out loudly and fussing, that's 2. So that would be cry with vigor. Cry with vigor. So after they assign these areas numbers, they go ahead and add it up. And you gotta know what they mean. That's the most important thing, you know. So they go like, if you add up everything from each area and you have a score of 0 to 3, 0 to 3 is the total number that you added up, okay? Then that will mean resuscitate. You're gonna start CPR, okay? That baby is not doing fine. You're gonna resuscitate the baby. If you added up all the numbers and then you got 46, you're gonna stimulate the baby or give it oxygen, that kind of stuff. Stimulate. Give oxygen. If you add up all the numbers and then you got 7 to 10, 10 is the most that you can have. You celebrate. That celebration just means you take the baby to the NICU for monitoring. Okay, you just take them, transfer them to the NICU for monitoring. They're doing well. Okay. Any questions about the APGAR? Usually done at 1 minute and 5 minutes to determine the progression of the resuscitation. Umbilical arterial catheter. Now, this is a catheter that we put inside the umbilical artery, because once you cut that umbilical cord, okay, then the baby begins to make transition. So that artery in there becomes real artery like what we have. You know? So if you catch it before it spasms, because there's no more blood flow through it, we can put a catheter in there. Okay, it's just like doing an airline in the adult. We put a catheter in there that is called the umbilical arterial catheter, and then we can use that catheter, because it's an airline, we can use it to do blood gases. So if a baby has a need for frequent blood gas analysis, instead of sticking the baby all the time to cause it to cry and give it pain, we can just draw the blood from there. Okay? But the truth is that we always avoid getting blood from the baby. We use more non-invasive monitors, okay, in monitoring the baby. The stack monitor, transcutaneous monitor, all of that. Because in the entire baby, the amount of blood that they get is between 100 to 150 milliliter. The entire baby. Very small volume, a very small blood volume. So we don't need to keep on drawing their blood out, you know. So that's why we prefer to use non-invasive monitors for babies. We can also use the umbilical arterial catheter for blood pressure monitoring, just like we do in the adults. The airline, if you want to monitor their blood pressure continuously, then you can use the umbilical arterial catheter to do that as well. Any questions? I'm not going to go through placements, pretty much like the airline. You have to have make it like a sterile field. Okay, do everything that you would do like you do in the airline, and then insert the catheter until you have blood return into the catheter. That would mean that you are inside the artery. Okay, and then you hook it up to the transducer, and then we start reading out pressures. Complications of umbilical arterial catheter. Thrombus formation. Thrombus is clots. Okay? Closed formation at the tip of the catheter may result in NIC. Now, NIC, it means when you have that clot, that blocks blood flow to the intestine. So it blocks blood flow to the intestine, and then the baby can develop what they call the necrotism. Necrotism enterocolitis. NIC. So, it's when the intestine is not getting adequate oxygen because of the thrombus. And when babies have bowel movement, you know, the smell is kind of like it's going to smell all over the hospital, you know. Their bowel will smell like crazy. Bacterial infection. And if that is happening to a baby, you may stop feeding them with milk. You avoid of feeding the baby with milk. Okay? Otherwise, that's going to cause more bacteria to build up in the intestine. Vessel perforation can occur as well. You have to know how to do this. In fact, in any resuscitation, there must be at least one person in attendance that knows how to do everything about resuscitation. If it comes to intubation, he can do it. If it comes to inserting the arterial, oblique arterial catheter, he can do whatever. So in every resuscitation, there should be at least one person that is capable of doing everything that can be done. Now, when you anticipate that you're going to have something serious with the baby, you may have two. You have two people that will know everything about resuscitation. So, we have to be very careful in inserting the catheter. It's just like doing a blood gas. You have to, if you're doing the radial artery, you have to go in at 45 degrees to prevent loss rate in the artery. If you're doing the brachial artery or the femoral artery, 90 degrees. So you have to have the appropriate technique, not to loss rate the artery. Hemorrhage, yeah, the baby can bleed. Okay? We have to make sure that the baby's blood has the ability to clot on time, so that they don't bleed to death. And then spasm of the blood vessel can occur too. Okay, you can have vasospasm, and then that can bring about reduction of blood flow. Okay, because the vessels will be squeezed. Any questions about neonatal resuscitation? So what we're going to do is, at some point, we're going to have, a short lab, like 2 hours, so that you will get to intubate the baby, look into their airway, look at their ET tube and stuff that we use for them. Okay? Good enough? All right.